Shankar?
Yes, Vishal, you can start.
Very good evening. I am Dr. Vishal Panichar, Stroke Fellow under Dr. G.G. Kulitulam, sir. Today's faculty is Dr. Taj Srinivas, Senior Interventional Neurologist. Today's topic is intracranial vessel wall. Today's topic is intracranial vessel wall imaging. So objectives of today's talk is technical aspects of vessel wall imaging, clinical indication, interpretation, and its pitfalls. When we talk about a vessel wall imaging, conventionally it is luminal imaging techniques like MR angiogram, CT angiogram, and the gold standard DSA. And the newer modality is the vessel wall imaging. When talking about the vessel wall imaging, it is an early promising tool for vasculopathy differentiation and characterization. Coming to the technical aspects of the vessel wall imaging, the principal technical requirement for an intracranial vessel wall MR imaging are following. We need a high spatial resolution image, multiplanar 2D acquisition or 3D acquisition, multiple tissue weighting, suppression of the signal in luminal blood and CSF. So we all know the intracranial vessel is of small size, that is only a 3 mm to 5 mm in size, and 1/10 will be of the size of the vessel wall, that is a 0.3 to 0.5 millimeter. So we need a high spatial resolution with the 3 Tesla will be the ideal, which has got a high signal to noise ratio. And we need a multiplanar 2D imaging or 3D imaging with reconstruction. Here, the first image is showing a 2D image, which is optimized for the vessel wall imaging. Here we can see the middle cerebral artery with a thin wall, and this is an ACA, which is also a normal wall, thin wall. And this is the 3D imaging of the same patient. And for comparison, this is a zoomed image. This is the appearance of a normal vessel wall in 2D image, and this will be the appearance of vessel wall on 3D image. So we need not only that, we need a short and long axis plane for the detailed assessment of the vessel wall. Here we can see the vessel wall in a cross-sectional view in a short axis. This is a patient with a ICAD or intracranial adenomatous plaque, showing the vessel wall thickening, the small lumen and eccentric vessel wall thickening. And here we can, in long axis also, we can see the vessel wall thickening. This is the lumen of the vessel, and this is the eccentric thickening of the vessel wall. So we need multiple tissue weighting also. MR time of flight can be used as a localizer for subsequent vessel wall sequencing. We need a high resolution T1 imaging, T2 imaging, and high resolution T1 contrast imaging also required for vessel wall characterization. As you all know, the vessel wall is of small size, that is a 0.3 to 0.5 mm in size. And so small voxel size is of this is the voxel size, and if it is the vessel wall, inside the vessel there will be blood, and outside it is CSF. So the voxel will be covering both the blood and the CSF. So we need the suppression of the blood and CSF. Black blood and the CSF spinal fluid suppression is necessary for visualization of the vessel wall pathology and the vessel wall in normal tissue also. We have different techniques. In 2D, we have spin echo technique, double inversion recovery preparation, and 3D sequence, we have variable refocusing flip angle technique. These are the techniques for obtaining the vessel wall image. In first image, we can see a normal MRI T1 contrast image. There is a lot of enhancement along the blood vessels, that is MCA and its branches are getting enhanced. When we suppress this with the sequence of optimized for the vessel wall imaging, we can see the pathology. There is a vessel wall thickening along the left middle cerebral artery. So in summary, we need a high spatial resolution, multiplanar 2D acquisition or 3D acquisition, multiple tissue weighting and suppression of signals in luminal and CSF for better visualization of the vessel wall. So what are the indications for vessel wall MR imaging? To differentiate among the causes of intracranial arterial narrowing, to identify symptomatic non-stenotic arterial disease, to assess the disease activity, to determine the plaque location relative to the branch artery ostia, to determine if aneurysm has ruptured. First, about how to differentiate among the causes of intracranial arterial narrowing. So we have a vessel wall MRI dogma here. This is the normal appearance. In normally the vessel wall will be thin. Normal vessel wall will be thin, and the lumen, there will be adequate lumen. And in T1 and T1 GAD image, there will not be any enhancement. In vasculitis, there will be luminal narrowing and the vessel wall will be thickened. And on contrast, there will be enhancement of vessel wall due to the inflammation of the vessel wall. In RCVS, what happens is there will be contraction, that is a myosin actin overlapping, which lead to the media thickening, and the vessel lumen will be narrowed, and there will not be any inflammation and no GAD enhancement. In what happens in dissection is there will be blood inside the vessel wall and eccentric narrowing of the blood, narrowing of the lumen, and the blood is T1 hyperintense, so there will be T1 hyperintensity, and contrast there will be enhancement also. In ICAD also there will be eccentric narrowing of the vessel wall, and there will not be any T1 hyperintensity, and gadolinium will show the enhancement of the vessel wall. This is how the normal vessel wall looks like. There will be, we can see, this is a enhanced image, zoomed out imaging, shows a vessel wall is barely visible. This is a normal vessel wall. The lumen, there is no narrowing, and the vessel wall is visible as a very thin walled structure. This is the cross-sectional imaging image or the short axis imaging showing a nice circumferential lumen with the thin walled vessel. What happens in vasculitis, here is an MR imaging showing multiple basilar artery involvement. There is stenosis of the posterior cerebral artery and superior cerebellar artery. In vasculitis, we have the contrast enhancement, which is a smooth enhancement of the vessel wall, and there's a smooth linear enhancement, and there is luminal narrowing also. This is the basilar artery, and this is the posterior cerebral artery, which is along the, showing a linear enhancement of the vessel wall, smooth and linear enhancement of the vessel wall, suggestive of vasculitis. This is another patient with secondary giant cell arteritis, where the multiple vessels are showing vessel wall thickening and luminal narrowing, and there will be contrast enhancement, which is also a smooth enhancement of the vessel wall. Coming to the vasoconstriction, in patients with vasoconstriction, this is a MRI. This is a DSA showing a patient with a reversible cerebral vasoconstriction syndrome. In vessel wall imaging, there will be narrowing of the vessel wall, and there is luminal narrowing with the thick vessel walls, and there will not be any contrast enhancement. This is a normal vessel wall imaging for comparison. This shows a thickening of the vessel wall with the narrowing of the lumen, suggestive of vasoconstriction. Next, about the dissection. Dissection, there will be eccentric narrowing with the T1 hyperintensity. This is a T1 imaging showing without any gadolinium, showing the enhancement of the vessel wall along the vessel wall with the luminal narrowing, and this is a zoomed imaging showing the similar finding. What happens is the blood will be escaped with the tear in the intima into the media, and there will be flap enhancement. So blood is T1 hyperintense, so there will be T1 hyperintensity and also T1 GAD hyper enhancement also will be seen. So coming to the atherosclerotic plaque, this image showing a basilar stenosis, and in atherosclerotic plaque, the T1 we can see the vessel wall thickening with eccentric luminal narrowing, and gadolinium there will be enhancement of the vessel wall. And this is the typical appearance of a throma. There will be a layered appearance that is seen with the T1 contrast imaging. The fibrous capsule will be seen as a hyperintensity followed by non-enhancing hypointensely intense area and followed by a hyperintense adventitia or the cap. This is a typical layered appearance of the atherosclerotic plaque. So what is an atherosclerotic plaque? We have a fibrous cap followed by the lipid core layer, and sometimes there will be calcification. As the plaque advances, there will be hemorrhage because of the fissuring in the fibrous cap, and intraplaque hemorrhages can be seen. In case of any intraplaque hemorrhages, there will be T1 hyperintensity also. So this is the typical appearance, that is the layered appearance of the atherosclerotic plaque in vessel wall imaging. So few words of the vasa vasorum. This is this A is the intracranial vessel and B is the extracranial vessel. What is the difference? The intracranial vessel has got a thick internal elastic lamina and without any external elastic lamina, and in adventitia there will not be any vasa vasorum in intracranial vessel. But in extracranial vessel, there will be external elastic lamina will be well formed without any internal elastic lamina, and the adventitia there will be prominent vasa vasorum. As there is, with the progression of atherosclerosis, the media in intimal layer get thickened initially, followed by the intimal layer thickening, followed by the media thickening, and there will be hypertrophy of the muscular layers, and this lead to the increased demand of the nutrients. Usually the nutrients of the intracranial vessels are from the CSF outside and from the blood inside. So with the progressive thickening of the vessel wall and the media thickening and increased muscular layer, usually a threshold of 29 is set. Once it crosses the 29 layer of muscle, there will be vasa vasorum, internal and external proliferation into the adventitia of the vessel wall because of the increased demand. And this can lead to the plaque formation, progression, and is also involved in the pathogenesis of the intraplaque hemorrhage and plaque inflammation. Next indication is to identify symptomatic non-stenotic disease. This is a 64-year-old female with right hemiplegia, MR imaging showing a normal vessel wall. So patient undergo standard stroke workup, and even after all workup, there is no cause was found. 25 to 30% of all strokes are cryptogenic. So in cryptogenic stroke, we can evaluate the patient with intracranial vessel wall imaging to find out any cause along this. This patient undergone a intracranial vessel wall imaging, and this is a cross-sectional imaging of the MCA showing the thickening of the vessel wall with the eccentric narrowing of the lumen. This is the lumen, and this is the vessel wall. This is the vessel wall, and this is the lumen. So here, on contrast, there is fibrous cap hyperintensity with the eccentric narrowing of the lumen, suggestive of an ICAT. This is a zoomed image of this. So coming to the atherosclerosis remodeling, what is a positive remodeling and what is negative remodeling? In positive remodeling, this is a normal vessel. The white thing is the lumen, and the red thing is the vessel wall. When there is a atheroma or plaque formation, usually as a compensation, the vessel wall get thickened and bulge outwards, and the lumen size remains same. So during normal imaging like TSA, vessel wall, the vessel will appear normally since it images the lumen. In negative or constructive model, as there is formation of atheroma, the vessel is not enlarged, but this atheroma causes the progressive constriction of the lumen, lead to the constriction or stenosis. In these cases, the DSA will be abnormal initially. Even if it is a positively remodeled artery, ultimately there will be stenosis in later time. This is a positive remodel showing a enlargement of the vessel wall, enlargement of vessel, and the lumen is relatively normal. In negative remodeling, initially itself the narrowing of the lumen will happens with the thickening of the vessel wall. It's also important to assess the disease activity. There's a patient with the right MCA tertiary infarct, and there is a M1 cutoff on Galileo enhanced imaging of the vessel wall, showing a T1 hyperintensity on acute phase, usually disappeared by 6 months or later. It is also seen in vasculitis also, but it is not much reliable in vasculitis. Vasculitic patient, even after successful treatment and remission, the enhancement may remain like that only. We can determine the plaque location relative to the branch artery or ostia with this vessel wall imaging. This is a subcortical infarct, and the patient undergone a vessel wall imaging and showing a superior part of the MCA, showing a vessel wall thickening, and the ostia nearby is also occluded. This is the ostia which get occluded by this intraarterial plaque. So based on the location of the plaque, the vessel wall on cross section, we can divide it into anterior, posterior, superior, and inferior. Usually in MCA, the lenticule-striate artery arises from the superior posterior region. So when the superior or posterior regions are involved in the middle cerebral artery, the lenticule-striate artery can easily get obstructed and patient becomes symptomatic early. And also, if the patient was planned for any stenting, this imaging finding becomes important, because the anterior or inferiorly located plaque will not become symptomatic after the stenting, but the superiorly located plaque can dislodge into the lenticular-striate artery following stenting and may produce worsening of the stroke symptoms. Can be also used as a target for biopsy in suspected CNS vasculitis. This is a patient with CNS vasculitis, and here there is a venular hyperintensity on vessel wall imaging, and this patient had undergone biopsy from the targeted site and suggestive of a vasculitis. There will be intramural inflammatory cells involvement, and this can lead to a gold standard diagnosis by biopsy. We can determine whether an aneurysm has ruptured or not from the vessel wall imaging. In a patient presented with a thunderclap headache and the MR imaging showing an aneurysm, or at investigation there is no evidence of bleed, the vessel wall imaging is showing the hyperintensity along the aneurysmal wall, which is suggestive of rupture of the aneurysm, and it also predicts these aneurysm has got high risk for rupturing also. So this is the American Society of Neuroradiology recommendation. Clinical indication: the wall imaging is likely useful adjunct to the conventional imaging to differentiate among the causes of intra-arterial narrowing, to identify symptomatic non-stenotic disease in intracranial disease. Imaging is possibly useful adjunct to the conventional imaging to determine the plaque location relative to the branch artery ostia, to assess the atherosclerotic plaque activity, to assess the vasculitis activity, to select intracranial target for biopsy in suspected vasculitis, to determine if an aneurysm has ruptured or not. What are the challenges in interpretation of the vessel wall imaging? Is it straightforward? This is a case with a vessel wall with a left MCA tertiary infarct, male with a left MCA tertiary infarct who undergone a vessel wall imaging. This is a T1 contrast imaging, shows a uniform small enhancement along the superior wall. Is it an adenoma? Is it a dissection? Actually, it is a vessel that is a vein adjacent to the artery mistaken as atherosclerosis. So we need a multiple plane imaging and the characterization of the vessel wall to make the correct diagnosis. This is a second case, 52-year-old female with ataxia showing a right cerebellar infarct, and this vessel wall imaging. This is a non-contrast enhancement and contrast imaging showing an eccentric narrowing of the lumen with the vessel wall thickening appearance. This patient had undergone a MR angiogram, contrast enhanced. It showed the vessel is filling with gadolinium. So there is no narrowing of the vessel wall. And what is this? This is the artifact due to the slow turbulent flow, which can mimic as a vessel wall abnormality. We can get the slow turbulent flow with the dilated vessels, like whenever there is an aneurysm or a tight stenosis which produces slow flow. In these cases, the vessel wall imaging may show abnormality. This is a patient with the right-sided weakness, and she has got atrial fibrillation also, and the MR imaging showing left-sided tertiary infarct, and the MR angio also showing a M1 cutoff. And this is the vessel wall imaging. This is a non-contrast vessel wall imaging showing a hyperintensity, that is a vessel wall abnormality at the Sylvian fissure. Is it a dissection or atherosclerosis? So actually this is a luminal thrombus which can mimic as a vessel wall abnormality in T1 non-GAD. Like a slow flow in a dilated vessel, the luminal thrombus also can lead to the mimicking the vessel wall abnormality. This is another case showing a watershed infarct along the right MCA territory, and the angio showing a stenosis of the vessel abnormality along the M1 segment, and MR, and this is a MR vessel wall imaging showing an eccentric vessel wall thickening with the luminal narrowing. And here there is an T1 hyperintensity in non-gadolinium enhanced imaging. So T1 gadolinium enhancement can be seen whenever there is a blood. Is it dissection? Blood in a vessel is not necessarily dissection. Intraplaque hemorrhage can present as dissection. So characterization of the vessel wall abnormality with a multiple imaging can differentiate between the dissection and intraplaque hemorrhage. This is an 81-year-old female with a cerebellar infarct, and there is a uniform enhancement of the vessel wall with the post-gadolinium enhancement. This vessel wall get linearly enhanced. Is it a vasculitis? Actually, this is not vasculitis. This is vasa vasorum. As the age advances, there is increased formation of the vasa vasorum, which will be surrounding the vessel wall. This is the vasa vasorum that supplies the vessel wall. This is the cross-sectional zoomed imaging showing the vasa vasorum that supplies the media of adventitia. As the age advances, the vasa vasorum related atherosclerosis increases, and which can look like vasculitis. And this is the last case. 59-year-old female with atrial fibrillation came with a left MCA tertiary occlusion. This is a non-enhanced CT showing thrombus, undergone angio and show left MCA occlusion. She undergone thrombectomy. By following the thrombectomy, the vessel wall, the circulation was became normal, and she undergone the vessel wall imaging. Here we can see there is left MCA M1 region long axis. There is an enhancement along the vessel wall. There is a linear enhancement along the vessel wall. This is a cross section showing the linear enhancement, smooth enhancement along the vessel wall with the lumen intact. Is it a vasculitis? Post thrombectomy can produce endothelial injury, which can look like vasculitis on vessel wall imaging. So, in summary, these are the pitfalls commonly seen: the vein mimicking as enhancing plaque, slow blood flow mimicking a vessel wall abnormality, luminal thrombus mimics vessel wall disease, and all intramural blood are not dissection. There can be intraplaque hemorrhage also. Enhancing vasa vasorum can mimic as vasculitis, particularly in elderly patients. Be cautious. Post-thrombectomy patient can mimic vasculitis because of the endothelial injury and contrast enhancement. So, key points for interpretation. While interpreting vessel wall imaging, confirm the finding in multiple plane, ideally in multiple tissue weighting. Consider all sequence to be needed if there is vessel wall thickening or enhancement. Recognize the common pitfall like age-related vasa vasorum enhancement. Slow flow can mimic as vessel wall thickening or enhancement. Normal enhanced vein close to artery, there may be a T1 enhancement on non-contrast imaging. The effect of therapy like thrombectomy can lead to the smooth vessel wall imaging, looks like vasculitis. So clinical, always seek knowledge from the clinical context also big for making the diagnosis. Thank you all. Thanks for listening.
Hi, Vishal.
Hello, sir.
Hi, what is the format of this meeting? Sorry, do we discuss questions at the end, or do you or the audience have some questions and we can discuss them, or you can put it in the chat box. Nice, interesting presentation. You covered almost all aspects of vessel wall imaging.
Yes, sir.
It's better to discuss if there are any questions and doubts.
Jayashankar?
Sir, if any more points you can add, you can speak, sir. And by the time I will type if there is any.
Oh, okay.
No.
Okay, so Vishal, from your reading,
Yes, sir.
you showed a case of giant cell arteritis, right?
Yes, sir.
But most of the vessels you were showing were extracranial vessels in that
Yes,
image.
sir. Vertebral artery. Yes, sir.
Yeah. So you were showing the V3 and V4. So we know that even with aging, the proximal intracranial vessels can have vasovasorum. And
Yes,
many a times I've seen the radiologists also comment on the ICA, which is extracranial, and even the proximal intracranial ICA can have vasovasorum, and that can potentially enhance. So these areas where you're showing can potentially have vasovasorum.
Yes, sir.
So of course, clinical features and everything will sort of help in diagnosing. But just to be careful that, as you had mentioned in your presentation, that the extracranial vessels have vasovasorum, intracranial don't, but proximal intracranial vessels can still have vasovasorum.
Okay, sir.
Okay. And with regards to vasculitis, it is all three layers are inflamed actually. So is it always concentric as you mentioned here?
No, sir. Can be eccentric also.
Yeah, so
Usually it is concentric.
Yes. In nearly 2/3, it is 2/3 of patients you would get it as concentric thickening and enhancement. And you've not discussed about the grade of enhancement. So if you always compare it with the pituitary stalk.
Okay, sir.
Okay, so the pituitary stalk enhances in post-gadolinium imaging, T1 imaging. So if it enhances nearly up to the pituitary stalk, because in vasculitis you get very avid enhancement, it's grade 2 enhancement. And as you said, rightly said, not in all patients it will be concentric. Some patients can be eccentric. But even in patients which are eccentric, it's nearly 2/3 rather than less than 2/3 of the wall. So how will you differentiate if it is
In eccentric enhancement, the differential diagnosis will be dissection. In dissection, there will be T1 hyperintensity also, non-contrast and hyperintensity. And
if it is an
atherosclerosis, there a layered appearance will be there, like fibrous capsule, hypointensity, and adventitial hyperintensity will be there.
So the adventitial hyperintensity is because of what? The peripheral enhancement.
Peripheral vasovasorum.
Vasovasorum, yes. And you always want to look at the T2 imaging there.
T2, there will be fibrous cap hyperintensity.
So
atherosclerosis.
This has really helped in differentiating, at least in a few cases where there was a question about could it be vasculitis or atherosclerotic plaque. And if you carefully look at the T2 imaging, if you have a juxtaluminal, meaning the fibrous cap is juxtaluminal. So if you have a hyperintensity there, it will help you differentiate between vasculitis and atherosclerosis.
Yes. Okay.
And you talked about the remodeling, positive and negative remodeling, right?
Yes, sir.
So where is it common, positive remodeling? Anterior circulation, it's usually common in the
posterior circulation, it is positively remodeled, and anterior circulation is usually negative.
More commonly negatively remodeled. And what is the mechanism of stroke and positive remodeling and negative remodeling?
In positive remodeling, there will be increased atheroma, that is the plaque load is low. So thromboembolism is more common in positively remodeled.
It is more plaque rupture. It's an active plaque. In an anterior circulation, the negatively remodeled plaques are more calcific.
Hemodynamic.
Hemodynamic. And wherever there is narrowing, you get what is called as increase in the shear stress, wall stress. And that tends to take off the endothelium, and then platelets clump forms there and thrombus forms there, and then that can embolize or it can be hemodynamic. Both of these are possible. As you showed me one case where there's a bifurcation T1 hyperintensity. So normally, whatever is at the bifurcation is usually a clot. Right? ICAD, vasculitis, very uncommon. ICAD is usually whenever the bifurcation is involved, we tend to say it is not intracranial atherosclerotic disease, at least in the MCA. Similarly, when there is a narrowing involving the terminal ICA and the A1 and M1, generally it's not atherosclerotic.
Okay, sir.
You didn't talk about Moya disease at all.
In Moya disease, there will be involvement of the terminal ICA and the M1 segment, and there will be concentric wall thickening also. And there will not be any enhancement on T1 gadolinium.
Yeah. And it's a negatively remodeled artery.
Negatively remodeled artery.
So the media thins out, but the intima is thickened. So the wall thickness is still sort of maintained in Moya disease. And of course, there won't be any enhancement. There can be minimal enhancement sometimes, grade 1 enhancement. Similarly, in RCBS, there can be sometimes grade 1 enhancement.
Okay, sir.
And we have started doing whole brain vessel wall. And in the 3D vessel wall MRI, you can get the whole brain sequencing. And if you're able to do that, then if you see some enhancement, usually, as you said, vanillitis, then targeting your biopsy to that part of the tissue can yield. I think in one study, nearly 70–80% yield was there. There's only one study, I think, which came with whole brain vessel wall MRI. So one other thing is we get all these focal vasculitis, focal vasculopathies. You get these focal concentric young ladies actually in the early 30s, late 20s. Many of them tend to remain quiescent also. And in one odd case, I had done CSF and serum varicella IgG. Some of them can be it can be varicella. So I tend to do that. In one patient, there was patient had Fabry's disease. Then had this terminal ICA with enhancement, concentric enhancement, then progress. That was the one patient who progressively, then arterial, the lumen progressively narrowed down and we had to go for a bypass. But majority had remained stable.
Okay. Hello, sir. One doubt from the audience is from Dr. Lima asking what is the role of vessel wall imaging childhood stroke?
I've not done vessel wall MRI in childhood stroke so far. So I really don't know. I mean, only thing I would say probably if the patient has some Moya phenomenon or Moya disease, that's when I think maybe it would be helpful. But personally, I have not done much in pediatric age group.
Okay, then shall we wind up, sir?
Yeah, sure. I mean, if there are no further questions, then
thank you for coming. In future also, we would like to have you as a person for any other interesting topics, sir.
Sure, not a problem. Yeah, but it was well presented, Vishal. I think you've covered most of it. So, I mean, we can always discuss if there are any questions, because many a times I myself am confused, like whether it could be vasculitis or atherosclerosis. Most times than not, it is atherosclerosis than vasculitis. And I think it is useful to look at the DSA as well as the MRI and try to see if it is, even on the DSA, you get a clue whether it's eccentric or it is concentric. And also looking at if it is involving the terminal ICA, including A1, M1, then you be very careful to say that it is just atherosclerosis. And as you know, the anterior circulation is negatively remodeled. Aggressive plasty may cause rupture, whereas posterior circulation is more resilient. Plasty and stenting, the patients tend to accommodate. Only thing is just be careful in the basilar circulation that you have these perforators coming. You have very well demonstrated the osteal involvement. Of course, perforators you're not going to see well. We have this expert CT angiography. And of course, depending upon the machine, if it's Siemens, you'll get a Dyna CT, where you can potentially try to see which wall it is. And like in the posterior circulation, the lateral and posterolateral walls, then be very, very careful about stenting in the acute phase and even in the subacute phase. And in the anterior circulation, the posterior-superior wall is tending to have this perforators coming up. Again, if you are keen to know about hemodynamics, a lot of it is what is the there are two types of stressors on the wall of the artery, which is a normal stress and a shear stress. So the shear stress plays a huge role, it seems, and low shear causes much more problem. So if you see narrowing, at the level of the narrowing, the shear stress is much higher, and beyond the narrowing, the shear stress is lower. Wherever the shear stress is high, it is anti-plaque forming, and wherever the shear stress is low, it tends to form plaques. Similarly, that is what you see, like if you have the perforators, the shear stress tends to be in the wall opposite to the wall. Shear stress tends to be low in the wall opposite to be the perforators, and the plaques form generally away from the perforators, so we are okay. So I think if hemodynamics is very interesting, and if you have a curved artery, sometimes patients don't have any atherosclerotic risk factors, but still we see plaques. It may all depend upon how the arteries are, the geometry of the arteries, the curvature of the arteries, and so on and so forth. So I think to have a perfect stent is to have a stent which has a very small strut thickness. And of course, coronary stents are much thicker, the struts, if you see. So we have seen instant restenosis even in coronary stents. And some of the reason I think is because of the strut thickness. And the benefit, of course, is the drug elution. We know that in the first 6 months, you get neointimal hyperplasia, and generally beyond that, it is neoatherosclerosis. And the drug which we give tends to prevent the neointimal hyperplasia. So once the neointimal hyperplasia develops, then wall shear gets affected beyond that narrow area, and that can cause neoatherosclerosis. So I think the future would be to develop a stent which will be able to elute drug, better radial force, and which will have a much smaller strut thickness than the coronary stent. I think we can close here. There are no further questions.
Yes, sir. Thank you.
Thank you, sir.
Thanks, Shankar.